Okay, I'm going to take you on a little journey, the journey that I've been on for the last few years of my career, and take you through the process by which we have made use of routinely collected health data for surveillance of outcomes and process measures. So I got involved in this very early on in my academic career by doing some work for a couple of big public inquiries. The first one was the Bristol Royal Infirmary Inquiry, and the second one was Harold Shipman. So the Bristol Royal Infirmary Inquiry, as you probably are aware, was a big inquiry into paediatric cardiac surgery at Bristol Royal Infirmary, and I was asked to look at routinely collected hospital data to look back to see whether indeed Bristol was an outlier in terms of mortality for cardiac surgery. Now, there was no shortage of data to look at this. There were 5 or 6 different sources of data that could have been used to look at this question, and I particularly focused on hospital episode statistics data. And we looked at this administrative data over the whole of England and all the surgical centres that carried out paediatric cardiac surgery. And use these data to look at mortality rates for a range of procedures in children aged under 1 year and over 1 year. And you can see here, this is our analysis looking at hospital episode statistics data. And for children under 1 year, Bristol was a clear outlier for open procedures. Now, when we first began to look at the data, I was very skeptical that we would find anything interesting at all because of the reputation of administrative data. But very interestingly, our analyses also correlated with analysis of the cardiac surgeon's own data, which had been collected for a number of years that hadn't been looked at up until that time. They'd been sitting on a laptop in the Isle of Wight, I think, these data had never been looked at in this way before. So that was some work that we did for the Bristol Royal Infirmary Inquiry, and as a result of that, I was asked to do some work for the Shipman Inquiry by Anise Esmail, who was the medical advisor to Dame Janet Smith. Now, Harold Shipman was quite a different character to the surgeons. He was a serial killer, so this wasn't a question around quality of care, and we were asked to look at statistical techniques to see whether we could find other psychopathic serial killing GPs within the population. We were given data for 1,000 GPs, one of which was Harold Shipman, but we only had the codes. We didn't know which GP was Shipman. So we were given mortality data over a period of 9 years for 1,000 GPs. We were given the practice list size, and we calculated mortality rates and used statistical methods which I wasn't familiar with at the time, statistical process control charts, which actually hadn't been used very much in healthcare at the time that we were using these techniques. They've been developed for industrial uses for quality control. But we applied some of these techniques to the data. We did our analysis. We used Q-sum charts on these data, and we presented our analysis to the inquiry. And much to our relief, we had, in fact, identified Shipman as an outlier on these Q-sum charts. And a Q-sum chart is simply some kind of a function between your observed mortality or whatever outcome you want to look at and your expected outcome, and you simply add this function to the previous year, and normally you would expect a sort of fairly random noise along the bottom of this graph, but if the unit of analysis, in this case GP, is out of control, so to speak, to use a statistical process control chart vernacular, then the graph gently rises, or sometimes sharply rises, and crosses a threshold, which gives you an alarm. So this was all satisfying to us, I suppose, but one of the problems was that we also identified another 11 GPs using this particular threshold, some of which had much steeper lines than Shipman. And one of the explanations behind this was that we had very limited access to data for case mix adjustment. So we could only adjust very broadly for age, but we had no access to whether patients were living in nursing homes and sort of things like that. And it turned out that many of these GPs did have a very high proportion of patients living in nursing homes. However, we got a list of 1,000 GPs and whittled it down to 12 GPs, which is some advance. We, after that, turned back to hospital episode statistics. Now, hospital episode statistics is a very rich source of data, an electronic record of every inpatient or day case episode of patient care in every NHS public hospital in England. There's a similar system in Scotland, Wales, and Northern Ireland. Some 19 million records a year for inpatient and day cases, 300 fields of information, including details such as sex, age, and the geographical area of residence, a diagnosis, procedures, some 20 or 30 diagnosis or procedure fields, whether a patient was admitted as an emergency or planned, and how they left hospital, whether they went home, whether they were transferred to another hospital, or whether they died. And more recently, added to these data, we have access to A&E data, diagnostic and imaging data, and outpatient data as well. So why use hospital episode statistics? Well, they're comprehensive. They're collected by all NHS trusts across the country on all patients. I would say an advantage of these data is that the coding of data are separate from clinician, although increasingly we're getting clinician input into coding of these data, which I think is valuable. Anyone can access these data, or at least that's the theory. It's been more difficult recently to access these data, as I'm sure many of you are aware. And it's relatively current. We get updates every month, so we will be looking at admissions that occurred just around about 3 months ago. So it's relatively recent. It's not real time, but it's near real time. However, there are challenges and there are issues. One of the main arguments for not using these data are that how can you possibly adjust for case mix, the severity of illness of patients going into different hospitals with these fairly rudimentary fields. We've done a lot of work in looking at the ability of administrative data to predict outcomes such as mortality, readmissions, etc., to enable us to properly adjust for case mix between hospitals. This is a paper we published in the BMJ a few years ago, comparing risk prediction models, so case mix adjustment models based on administrative data with those based on clinical data. A very basic model using just age and sex and year, an intermediate model using whether a patient was admitted as an emergency or not, and a rather full model using a full range of fields available to us. And you can see that this measure of performance of our models matches fairly well with the performance of the cardiac surgeon's own risk adjustment model for coronary artery bypass grafts. We actually get better case mix adjustment or risk prediction for abdominal aortic aneurysm for vascular surgery, and slightly better than the best model available derived from clinical data sets for colorectal excision for cancer. And currently, we have a range of fields and diagnoses that we can make these adjustments for: age, sex, socioeconomic deprivation, diagnostic groups. And we can build these models for individual diagnoses and individual procedures. So currently, we build around about 400 statistical models for a range of different outcomes, including mortality. So thousands of statistical models, and we can update these models each month. And also, routinely collected data has an advantage in terms of completeness. These are a couple of other papers that we published, which compares numbers of cases within hospital episode data with numbers of cases within comparative clinical audit databases. And here, for vascular surgery, we have about 4 times as many cases within HES as collected by the surgeons. And for colorectal surgery, admittedly, these are quite old registers now, we have around about twice as many patients, procedures in our data than do the clinical registries. There are other challenges. We need to take into account trends. It's quite difficult in dealing with transfers as how to attribute outcomes. There are issues around where you take the diagnosis. Do you take it sort of at the first episode of the mission or the next episode? There are issues around adjusting for comorbidity. Palliative care coding has become an issue for that. But beyond that, it's a useful data set, and it's often the best we have, and often better than clinical data sets that are available. So how do we use these data? We have promoted the use of funnel plots, written about and for health by David Spiegelhalter, and we use these funnel plots to plot outcomes. But we've also returned 2 QSUM analyses, which are now we're basing on individual patient records. So perhaps this explains. So we've done a lot of work with a commercial company, Dr. Foster, who have taken our rather dull and dreary equations and SAS analysis codes and converted the work that we've done into usable analytical tools for hospitals. And this is an example of one of the tools that uses the QSUM analysis. Remember Harold Shipman, but we have much better adjustment for case mix. And each one of the points on this QSUM chart actually represents an individual patient. We are able, at an individual patient level, to give a probability of a particular outcome, in this case, death. We know whether a patient died or not. If we predict a low probability of death and the patient dies, the graph goes up a lot. If we predict a high probability of death and the patient dies, the graph still goes up, but it goes up by a small amount. And vice versa, if a patient survives and we predict that they would survive, the graph comes down, etc. So, and each patient QSUM statistic is added to the previous QSUM statistic, and normally you would expect random noise at the base there, but here you can see with this particular process something's happened around about February 14, and the chart has begun to climb and signaled on a couple of occasions. These charts feed into dashboards which can flag up alarms or alerts, which may flag up potential issues. We're not saying that necessarily this particular hospital is killing all its heart attack patients, but it might flag up potential issues that are worth drilling down into. And in fact, I cannot... yes. So, as a result of these analyses, we're looking at these things each month. And when we first started this system in 2007, we identified a particular hospital that was signalling a number of times. And of course, that particular hospital was Mid Staffordshire. They signaled 6 times for a number of different diagnoses and procedures in a matter of 8 months, where all other hospitals that had signaled had only signaled once. We copied these alerts to the Healthcare Commission at the time, and it was these alerts, together with patient concerns, that triggered the initial inquiry into care at Mid Staffordshire, and of course led to a number of large public inquiries which have had a huge impact on delivery of care in the NHS. We have also, just lastly, developed a re-identification system which gets around a little bit some of the issues around holding identifiable data. So this is a system that we work in collaboration with Dr. Foster. So Dr. Foster have access to anonymized data and run these analyses, providing them to hospitals. We at Imperial College have access to a limited range of identifiable fields, hospital ID and NHS number. The hospitals get the analysis. They then make a request to Imperial College through the tools, and we supply them with the identifiers. So Dr. Foster don't see the identifiers. We don't link the identifiers to our clinical records. They are linked on a computer within the NHS Trust. And this allows clinicians, managers within trusts to pull out records for case note reviews, clinical audits, and things, helping to identify some of the issues behind these alerts. Yeah, I am. Just to say, all of the work that we do is published in academic peer-reviewed journals, and I could talk about the future, etc. I will have just a slight rant about access to data, and I can see there are some representatives from HISIC in the background. I'm sure you're all aware of this, and the fallout from care.data, but that may be covered in questions. So thank you very much.